And good morning, doctors. This is Dr. Kronk with Spinal Kinetics. Welcome to this morning's webinar on the lazy doctor's way of doing impairment rating. Impairment rating is a topic that comes up a lot today in injury work. It's probably one of the most simplest things in the world to do. It's so easy to do. Actually, doctors that understand and know what they're doing with impairment rating are doing an impairment rating every evaluation that they're doing. So what we want to do is at Spinal Kinetics, I'm the Director of Education, and so we want to bring innovative programs to you twice a month on various topics. In this program, we want to talk about impairment rating. So to get started, as I get started, I just want to make sure that everyone can hear me. So if you could type, if anyone or one of my staff could type into the question box, yes, I can hear you just fine. I will proceed. So just anyone type into the box. Since I can't see an audience with this, okay, great. Thank you very much. Doctors, thank you very much. Okay, perfect. So the number one cause of pain and disability today is a spinal ligament injury. It's a spinal ligament condition, right? So you can have an acute injury and you can also have a chronic condition that is resultant from that acute injury that's no longer considered an acute injury, but it's still a spinal ligament impairment. So the number one cause of pain and disability today comes from the spinal ligaments. And a spinal ligament injury, you're all doctors, you all know it's called a sprain. That's what it's called. And we know that these ligaments that can be sprained are more than 220 in the spine. And we know that only 23 of those are discs. Okay, so a very small percentage of the ligaments of a spine are actually discs. And that's why we know we have so much problem with the over-reliance on MRI, because so much information about a ligament injury does not show up on an MRI, right? Now I want you to look at this slide real carefully. These are the common ligament symptoms. So if I go out to Medscape today, this is the symptoms that the whole world is actually saying are resultant and can be resultant from ligament injuries. Now, obviously, you know, when we get into migraine headaches, when we get into shoulder pain, when we get into back pain, when we get into neck pain, when we get into low back pain, these are so common. There are so many Americans that suffer chronically from this condition. And what is it caused from? Well, anytime you're going to diagnose something, your diagnosis is the examination of the symptoms. You look at the symptoms and then you go backwards to look for a physical cause of what's causing the problem. So we know that in injury work, an injury is called a lesion. It's also called a derangement. But a lesion, anytime we say a lesion, it's a region of an organ or tissue that has suffered damage through an injury or disease. Now, can I break my leg 20 years ago and still show a callus from the broken leg? Can I still show the remnants of that lesion? Yes. Was it acute 20 years ago? Yes. Is it acute now? No. Same with a ligament injury. Was it acute 20 years ago? Yes. Is there still excessive motion in the joint now? Yes. So we know again that these injury patterns are called derangements. They're just derangement patterns. And today, if a person is being treated by a doctor that's treating an injury, you want to have doctors that understand the lesion patterns. I mean, could you imagine treating with a doctor today that doesn't understand how the body is deranged in, say, a bone fracture or a gunshot wound or a burn or a dog bite? Yet today, millions of Americans actually suffer from spinal ligament injuries, and the real suffering that occurs most commonly is they're suffering with treating with a physician that does not even understand the derangement patterns that occurs when that tissue is damaged. And doctors, what is it? It's excessive motion and disc herniation in the spine. And remember, disc herniation is only 10% of the ligament structure. So today in medicine, we're getting more scientific, and we as spinal providers want to be more scientific. So we have this thing called a biomarker. It's been around forever, and it generally refers to a measurable indicator of some biological state or condition. So we have blood biomarkers. biomarkers. So if the sugar blood glucose level is at a certain level, we say, hey, this person has diabetes. If we see HIV antibodies in the blood, we say, hey, this person has HIV. So they're a measurable, keyword, measurable indicator of a biological state or condition. Now, we also have, guess what? Imaging biomarkers. And imaging biomarkers are incredible because they make practice incredibly easy for the spine practitioner. Right? We have biomarkers, and what does it indicate? It indicates a condition that's detectable on an image. So what kind of biomarkers are we talking about? Well, excessive motion is one of the most quantifiable biomarkers there is. So anytime you have a ligament condition, I don't care what joint it's in, it could be in the shoulder joint, the elbow joint, the wrist joint, the knee joint, or any of the spinal joints. If you damage the ligaments, it causes excessive motion to the joint. The more excessive motion there is, the more the damage that was indicated. And it's just that simple. Anybody that tries to make this more complicated at this point is just doing just that, is just making it more complicated. So the nice thing about imaging biomarkers is what? They're objective. Now, objective means anything that can be verified. What does subjective mean? It means anything that can't be verified and only exists within the examiner or the patient's mind. Right? So an opinion cannot be verified for accuracy. It simply can't. That's why we don't want to deal with opinions anymore. We want to deal with objective biomarkers. We want to deal with objective findings, and we want to deal with consensus as to what those mean, and then we don't need to deal with opinions anymore because the findings explain the condition, and that's the beauty of it. And that's what I've spent so much time talking about and teaching. So when we're dealing with spinal ligament injuries, the #1 biomarker is excessive motion, and it's picked up on stress radiology. It's not picked up on MRI, it's picked up on stress radiology. And it's the easiest thing in the world to do. Now, what we recommend, obviously, for Spinal Kinetics is that you send out to a reputable company that has a lot of experience in excessive motion testing, as our board-certified medical radiologists do. Now, can you tell from that chart where is the problem? The problem is quite simple. It's at C6. Where is it here? Well, it's quite simple. It's at C2. Where is it? Where is it here? Well, there's a number of areas in the spine, but the most excessive motion is found at C4 and C5. Right? So this is very, very easy to look at. And anybody can interpret this. This is a normal study. And what is the doctor doing? Well, the doctor is actually taking those findings, and then they're doing motor, sensory, or pain analysis to that level. And that's how you determine if that excessive motion is actually causing a condition that's active in the patient. Do they have an active motor problem, a muscle weakness, an active sensory problem, hyper or hypo sensitivity in a very defined area? Or do they have pain associated with that level? And with pain mapping, we know what pain areas we're looking at. So it's very, very simple today. Again, if you're going to do stress testing, we're a national stress testing company. You got to have good images. And this is what good images actually look like. Right? So today with X-ray, we just need good images, and we need good images of the lumbar spine if the provider is going to do lumbar analysis. This is not a good. This is commonly what we still get in. This is called plain film. This is not digital. And if you're going to take plain film, we have to have good images. And anybody who's doing ligament analysis, either acute injury for acute injuries or chronic analysis for the chronic pain patient that's suffering from a hidden, often undiagnosed spinal instability that is the cause of their problem. That is the #1 cause of pain and disability in the world today. Right? Now, I published a report that was the 3 biggest pitfalls with MRI and spinal ligament injury diagnosis. It has nothing to do with running down MRI. It has to do with acknowledging what MRI does and doesn't do when it comes to ligament testing. Now, anybody who wants a copy of that report, you just go out to smartinjuryradiology.com and you can have a copy of that report. Okay, so now when we look at MRI in that report, I'm going to tell you, hey, it doesn't address, even though a cervical study properly images the craniocervical junction, nothing is reported on it. Why? Because it's a disc study. It reports on what are the discs doing. Craniocervical junction ligament injury, here's the common acknowledged symptoms. That's why stress testing with X-ray is so important, because you want to properly diagnose this condition. On MRI, none of the other 9 ligaments that hold a motion unit together are ever indicated to be damaged, yet they can be seriously damaged. And how do we determine that? With excessive motion. And again, that's never picked up on an MRI. Plus, we can have a completely clean MRI that shows no disc herniation and have severe ligament damage in the patient. So there's 2 testing forms. There's MRI, which is good for the discs, 10% of the ligaments. And then there's stress testing with stress radiography and accurate measurements of the intersegmental motion patterns. At Spinal Kinetics, we trademarked the term computerized radiographic mensuration analysis, or CRMA, and that's what we provide. Now, we can also have a disc herniation that has no excessive motion above or below. We have a ligament injury and ligament damage here showing up, but when we have no excessive motion above, below, or at the level, this is you typically very easily corrects with conservative care. Now, if we have the same disc herniation with excessive motion above, below, or at the same level of the disc herniation, oftentimes that's still conservative care, but it usually takes a lot longer. So providers need to understand that. Patients deserve the right to understand what condition do they have and what's being treated and how long will it take to treat. And that's exactly what this type of testing tells the providers that understand the testing. That's why it's so incredibly important, right? So now, let's get into a couple of spinal ligament injury myths, or spinal ligament condition myths. And these myths are out there, and they're perpetuated by those that don't understand spinal ligament injuries. One, it's just a soft tissue injury. Well, everything that you see to the right is a human soft tissue. The most critical and the most valuable tissues in the body are soft, not hard. So if I go to the male penis, that's a soft tissue. There is no bone here. So, or if the testicles. So if we crushed a male testicle, no one would say it's just a soft tissue injury. Or if we punctured your heart and damaged it so that you could only use it about 25% of its capacity, no one would say, oh, that heart injury is just a soft tissue injury. No one would say an injury to the brain is just a soft tissue injury. So I think you get the idea. Now, the spinal ligament soft tissue is the #1 cause of chronic pain and disability in the world today. It's not just a soft tissue injury. As a matter of fact, it's one of the most costly injuries there are. Today in America, the American Pain Society says that chronic low back pain is estimated to cost $9,000 to $19,000 per patient annually. When we look in the when we look at the workers' compensation statistics, a low back injury today at the 1 year point has an average cost of about $50,000. The 3 year costs can have an average cost of over $250,000. These are not just soft tissue injuries. When we look at the longest pain studies out there, we find that average patients with chronic or chronic moderate to severe pain, severe would be somebody who medicates regularly for their condition, which is a lot of Americans. They're averaging $12,000 and above more in additional spending every single year. Now, healthcare costs for the migraine headache patient are 70% more than the healthcare costs for somebody who doesn't have a migraine headache. The reason why I have this craniocervical junction area up is because that's the area that the ligament doctor looks as a migraine. Oh, that's the symptom. Good. Now we're going to back up and look for the physical cause. Look to the craniocervical junction and you'll find it 9 out of 10 times. Right? So soft tissue injuries heal in 4 to 6 weeks. Well, I got news for those out there. Soft tissues heal in a 3-phase recovery cycle. And the first phase is 1 to 4 days. That's when there's intense inflammation. And so that's when the cells are coming in and they're getting rid, they're starting to actually come in and get rid of the damage. And now in phase 2, 4 to 21 days, damaged tissue is gotten rid of and new temporary tissue is being built. That's the first 21 days. After that, you have permanent tissue being built, replacing the temporary tissue, and all tissue is remodeling. And that remodeling takes up to 2 years to do. So this is not a 4 to 6 week cycle. Now it is a 4 to 6 week cycle for doctors that document and have such poor documentation that the only thing you can think of when you look at the documentation is the person has a mild sprain. Guidelines in Australia say that 40% of all whiplash cases, now this is a national government guideline, 40% of all whiplash cases should be improving and should be close to full recovery in what? Well, it says here in 12 weeks. Now that's not all that inconsistent with mild sprain recoveries. 60% say that they're going to still need care, need things over the next 12 months. Low property damage, low injury. State of Florida, 2000. All low crash area, no vehicles were traveling over 10 miles an hour. That's considered low impact. Does not involve bicycles or pedestrians. In 1999, there was 528 deaths. So stand here and tell somebody that you cannot be damaged with low property damage when you're looking at a dead person. Okay, these are some of the myths. Now, the nice thing is, and I love this slide by Warren Buffett, the more you learn, the more you earn. And spinal ligament injuries, anybody that puts their time into learning more about this and educating themselves, the more you earn, because there is such a high need for providers that understand this condition. Now, when we get into impairment rating, this whole webinar this morning is the lazy doctor's way to do impairment rating. Impairment rating is easy to do. First of all, impairment means the loss of use of, or the derangement of any body part, organ, or organ system, right? So is the spine an organ? Yes, it is. Is the spine can there be a derangement of the part? Yes, you can fracture it. You can cause excessive motion to it, or you can cause disc herniation to it. Those are the 3 things that you can derange in the spine. So when we're looking at impairment rating, this helps this helps attorneys Anybody that's helping or assisting to adjudicate benefits. Impairment rating, that's what impairment rating was set up to do. From its inception, the goals of the guides have been to provide standardized, objective, what does that mean? That means verifiable, approach to evaluating medical impairment. So the use of the guides, in Chapter 1, the guides provide concepts, definitions, and rules to evaluate patients with injuries or illnesses and to translate this evaluation into an impairment number to assist legal and other systems to calculate compensation. Now, anybody that, when I was in an injury practice, the AMA guides were one of my favorite things because I didn't need to have an opinion. I just needed to do an impairment rating. Now, the guides is of value only if the medical diagnosis is correct. And what do we use to get the correct medical diagnosis in a spine injury? Well, we use imaging biomarkers. Easiest thing in the world to use. Just already explained it above, right? Now, when we talk about the insurance industry, Colossus used to be owned by Computer Science Corporation, which just recently merged with DXC Technology. It's a major company. In their, on their website now, when they explain to the insurance industry that they're using Colossus, or why the benefit of using Colossus, why buy Colossus from us to use, this is what it's saying. It's the insurance industry's leading expert system for assisting adjusters in the evaluation of bodily injury claims. Colossus provides adjusters access to your company's claims data within a defined business process management framework for evaluating injuries, treatment, resolution, impairment, general damages, and settlement. Colossus helps your adjusters reduce variance and payouts as on similar bodily injury claims. Excuse me. Your adjusters can quickly interpret medical reports and look up definitions of injuries, treatments, complications, and permanent impairments using the 5th edition data. Through a series of interactive questions, Colossus guides your adjusters through an objective evaluation of medical treatment, degree of pain and suffering, degree of permanent impairment, and impact of the injury on the claimant's lifestyle. Those are called duties under duress and loss of enjoyment of life factors. So, at the conclusion of the Colossus consultation, a summary of the claim is provided and included a recommended settlement range. So if a patient has an impairment, it's your job to get all the providers that are trying to determine, all the professionals that are trying to determine benefits, it's your job to get them that information so that they can appropriately and easily determine benefits. Again, we said, look, impairment is a derangement of a body part. And it doesn't matter what body part. So if you deranged your upper extremities, there's an upper extremity chapter. If you deranged your lower extremities, there's a lower extremity. Spine, there's a spine. Heart, there's a heart. So you just go to that chapter and you take a look. If you're using the 5th edition, which is still the most commonly used edition out there today, it's the most commonly used for auto carriers. And personally, I don't care if you say no, the 6th edition, then you use the 6th edition. And somebody else says no, the 5th edition, then you use the 5th edition. Somebody else says no, the 4th edition, use the 4th edition. Somebody else says no, I like the 3rd edition, use the 3rd edition. And if somebody's old enough out there that they were with the 1st edition, they go, by God, I'm just using the 1st. Use the 1st. Okay? But the thing you want to use is you want to use impairment rating, the impairment rating guides for impairment rating. I mean, the 5th edition is so easy. I mean, there's a category that says, look, I don't have any findings of any kind. There's another category that says, hey, the only findings I have are, I have asymmetrical range of motion, or I have a disc herniation that was verified in an MRI that is completely healed. I got a category 2. Or I got a disc herniation that's continuing to cause residual problems, or I had to have a surgical procedure to fix it. That's category 3. Or I've got alteration motion segment integrity, which is defined by the AMA as excessive motion that meets a specific number criteria Here I am. If I have 2 levels of this or 2 levels of serious disc herniation and I have 2 levels of ongoing radicular complaint, here I am. Just that easy. Now, some providers say, well, look, I want to use the 6th edition. Okay, we'll use the 6th edition. The lazy way to use the 6th edition, I'm going to tell you right now, whoops, is to just use ImpairMaster. Now, nobody gets credit at Spinal Kinetics for referring people to ImpairMaster.com. It's a program that you use, I think it's $47 or $49 a month. I happen to love it. If we go out to ImpairMaster and we sign in, we'll use the 6th edition, and we sign in, we simply go and we say, okay, create a new report, today's webinar. Our patient is 45. I'm sorry for the typo above. Today's webinar. 45, he's right-handed, evaluator's Cronk. Good, we'll do this right here. Fantastic. Save. Gosh, we want to do an impairment rating. Oh, let's see, we've got a spine impairment rating. We'd like to do the cervical spine. We're going to an interview. Well, here's the motion segment lesions. Again, what does lesion mean? It means injuries. All right, do we have a disc herniation or alteration motion segment integrity? We have 2 levels of alteration motion segment integrity identified by a Spinal Kinetics report. Or we have 2 levels of disc herniation in this case. Or we have pseudoarthrosis, that's where we had a spinal fusion of some kind, spinal surgery of some kind. Spinal stenosis, I'm not going to deal with today. It's very easy to do, but I need to do something else with that. It's very uncommon that you're going to use this. Here's all your fractures, right? So we just go here, we say, well, what do we have? Well, we have imaging findings of intervertebral. Now we have 2 levels of alteration motion segment integrity. This says alteration at a single level. No, we need 2 levels. This is still alteration at a single level. No, we need 2 levels. Alteration at multiple levels with medical documented findings or with documented signs of residual radiculopathy at a single clinically appropriate level. Yeah, that's what we have. Okay, what's my impairment level? Well, my impairment level is 19%. Okay, good. So I go to physical examination. What do I have? Yeah, I have positive foraminal compression. Grade 2. Save. Drop this down 2 points. Why in the world would a positive orthopedic test drop it down? No one in the world knows that for sure. You just follow the guides. Do I have a reflex problem? Yeah, I have a reflex. I have new and asymmetrical reflexes. Great. Didn't do anything for it. Do I have atrophy? No. Do I have motor strength problem? Yeah, I have a grade 4. So grade 4 right here. Good. And what else do I have? Do I have clinical studies? Yes. I have imaging. Yes. Imaging gives me evidence here. Yes. Good. Now I have imaging evidence, and it just took me down another notch. It doesn't matter. You can argue with the guidelines all you want to. The bottom line is just do them, and when you're all done, save and finish, and now you have a report. This report is copied and pasted into any report that you want to produce. And that's the easiest way that I know to do impairment ratings. They're that easy to do. Now, this particular software also has, if I wanted to, and let's say I want to rate other things. Let's say I want to go into the central or peripheral nervous system, and I have a sleep disorder I want to rate. Okay, great. If I have other things that I want to rate, I'm telling you not to go hog wild. If you're saying that the sleep disorder is a part of the spinal problem, then it falls under the spinal impairment rating. So that's how easy it is to do these impairment ratings. I mean, they're that easy to do. And as smart injury physicians, I have a program that right now you're on a program for Spinal Kinetics. I'm the director of Spinal Kinetics, and I also run the American Spinal Injury and Impairment Consultants, where I do online training programs. And I have a smart injury physician program. We have physicians in that program that are right now charging $400 to $1,200 to do whole person impairment ratings for plaintiff attorneys. And all you're doing is, in order to do an impairment rating, you have to accrue all the medical records, all the records, and then look for the impairment findings. What does the patient actually have? Put it into the software, run a report, print out the report, and you have your impairment rating. It's just that simple. Now, when that's done, everyone is happy. One, the doctors are happy, right? Because you're not pressed so much anymore for, okay, that's subjective. You have objective documentation every step of the way, which will make you excessively happy in a medical legal system. It also, quite frankly, makes the attorney and attorney representatives and even the insurance representatives happy because they don't have to fight. So it's far less adversarial. Now, that's what I had to show you this morning on smart injury, or on impairment ratings. I try to keep these programs down to about a half hour, and then we do some question and answer. For those of you that are interested in finding out more or understanding more about smart injury education, a program that costs a whopping $97 to get involved with, you go out to Smart Injury Education. For those of you that are new to spinal ligament testing and you'd like to get started with spinal ligament testing, you can go out to www.thespinalkinetics.com and put out a query form. There's a form right on our website that you just put your name and a little bit of information about you, and somebody from our office will call, or you call 877-508-9729. After all of these programs, I entertain questions and answers. I do questions and answers. So what I'd like to do now is go ahead and, if you have any questions, go ahead and ask away. All right, so here's some great questions. 21 days to 2 years is a long range of time. What variables can cause such a wide range? Well, it's not such a wide range. If anybody has a scar, so if any of you have a bad scar, like I have a very bad, I was a catcher right up to the college level, and I had a very large chunk of my forearm taken out with a set of cleats. And so that scar changed continuously for over 2 years. Today you can barely see it. At the time, it was large, it was puffed out. So it's not the variable time, it's just this is how long they take to heal. Now, are there variables that can improve it, such as diet, or I'm not sure what HTN is, pre-existing injuries, weight? Of course those things all are going to have an impact on the healing of soft tissue injuries, and that you as doctors all know. That's what you're doing in your treatment programs, is you're minimizing those variables. For the overweight person, the person says, hey, overweight. For the overweight person, you can have what? Metabolic syndrome, which is a chronic inflammatory syndrome. Well, we want the inflammation to reduce down, and again, that's why the patients are coming to see you. Hope that answers that question. Great question. Will insurance carriers accept ratings from DCs compared to having ratings from MDs do it? Yes, absolutely. But let's say that they don't. Well, that is, so what? Okay. Do you realize how easy it is to, okay, so you send the patient in. So the patient goes in, you send a report that has you send a referral, you send the patient to a medical doctor. Let's say that the insurance company and the attorney is saying, oh my gosh, the insurance company won't accept an impairment rating from a DC, so we need an MD. So you send them into the MD with a report that says, this is what the patient has. Can you please verify or confirm or deny the existence of these things? The medical doctor takes that report, puts it into the medical record, now it's in a medical record. once it's in a medical record, sometimes the insurers will say, hey, we don't have a portion of our software where we can upload an impairment rating under chiropractic. Most of the insurers have that now. They used to not. Most of them have it now. If not, it just goes in under a medical record. You send the patient to a medical doctor, and you have a form that says this is the impairment rating. It goes into their medical report or their medical file, and now it can be entered. Please comment about Colossus not accepting impairment ratings from DCs. Just did. How do we get to use the impairment software? Yeah, again, you go to the impairment software is not ours. You go to impairmaster.com, and I think it's $49 or 47 bucks, and you sign up for it, and you have access to it, just like I showed you today. I mean, I'm just accessing my account. Do you know if verification of nurse practitioners are accepted as well? That I don't know. That's going to be see, here's the thing. I don't know the insurance software is enough to go, do they have a separate section for nurses under medical, or is it all under medical? So I don't know the answer to that question. So I don't know if a nurse practitioner can validate that. But here's the bottom line, doctors, is in my private practice in the 90s, I didn't care whether a medical doctor was validating it or who could accept it or not. I did it because it made it very easy to demonstrate the level of the condition and what the consensus was about that condition. Because you've got to remember, impairment rating is great for settling claims, right? And 99% of all claims settle without ever going to court. But they're also great when you go to court. So, you know, it's that easy. When a patient is so acute during initial visit, can barely flex neck or extend for flexion view, should we wait a few days? Yeah, absolutely. So, you know, first of all, I'll tell you from 1995 or 1996 till 2004, every patient that I thought I had an acute ligament injury on, I sent out to a company called Spinal Diagnostics for a test, and I didn't wait. You know, very few. Every once in a while, I would see a patient where I went, okay, this patient just absolutely cannot move. If they can't move, then you're not going to see excessive motion. Do some care. Document in your notes, the patient is so acute that they can't flex, they can't extend. I can't do a proper ligament analysis. I'm going to do some, you know, inflammatory reduction over the next week, 2 weeks, a month, whatever you're going to do. And when I have more range of motion, I'm then going to take flexion extension studies, and I'm going to send the patient out. Just that easy, just documentation. Should impairment rating be evaluated at the end of the case, at the time of diagnosis? Well, first of all, impairment rating can be done anytime, right? But a formalized rating is done where you're saying it's done in MMI. MMI is where you're going to look out for the next year, and you're going to say, no matter what I do, no matter how many more adjustments, how well the diet works, how much more weight loss the patient loses, how much more massage they have, how much more injections they have, how many more nerve burns they have, whatever it is that they're doing. If you look at that and say, look, I feel like I've tried everything, the patient is where they've gotten to where they're going to be, that's called MMI, maximum medical improvement. And you want maximum medical improvement to be for each condition, right? So let's say a patient has a low back injury and they have a neck injury. Well, MMI for the neck injury may be different than MMI for the low back injury. In other words, you may have a neck injury that's static and it's not improving at all, but you have a back injury that's continuing to improve. It may not have met MMI. Okay, great. This question I got to read a little bit. I'm very pleased with your reports on my submissions. I have one now that has a cervical disc herniation verified by MRI. Are other ligaments usually indicated when disc herniation is present, even if I cannot see the George's line breaking on? The only way you know is test it. So you don't know. So the only way you know is testing. So what the doctor is saying is, look, if I've got a verified disc herniation, how do I know if I've got excessive motion? And, you know, often are the other ligaments involved? Well, yes, often they are, but you can also have a compressive disc herniation where they're not. So the only way you know is to test. No other way to know. Great question, though. Fantastic questions this morning. You're welcome. Okay, doctors, any more questions? If there's any more questions, let me just scroll here. Great questions this morning. I really appreciate your questions, and I appreciate your attention. Obviously, like I said, we do programs. I try to keep these very, very short, right to the point. And so, anything else out there? If not, perfect. Awesome presentation. Hope you're getting the big bucks. I love it. Art, that's true. Okay, doctors, I'm going to let you go for this morning. Again, thank you. Have a great weekend. Have a great rest of the week. Thank you.